high atop the Audrey Plaza in beautiful downtown Wilmington, Delaware. We are the Podcast Pediatricians. I'm Rob Walter, and I am flying solo today for a little mini episode of the Podcast Pediatricians, wrapping up Season 10. This is a recording of the top 5 papers by me last July at Hot Topics Disney World, as captured by Audio Digest. And a little plug for Audio Digest. We get absolutely no money from them, but Audio Digest is a nice way to hear talks from around the country on great topics in pediatrics or other medical specialties that can fit nicely into a commute in your car to work. And I hope everyone out there is staying cool on this brutally hot spring and summer. I mean, it's so bad. And you enjoyed celebrating our nation's 250th birthday this week, and also watching us not suck in the World Cup compared to what we usually do. I thought I'd take a couple minutes and a special opportunity without Matt here to talk about something that he does not like to talk about, which of course is television. Yes, we have a book club together, but he just does not seem to enjoy quality television. And I'm hoping our listeners out there enjoyed the season finale of Hacks, which was just a sublime comedy, as well as The Bear, which went out in style. And I just was very, very happy to have Jamie Lee Curtis to see one more time at the end of that show. But the greatest television show going, and I put it up there with Mary Tyler Moore, MASH and Cheers, and The Wire, and The Sopranos, is The Pitt. There's never been a television show highlighting real medical issues in such a realistic way. I could not even watch ER back in the day, or certainly Grey's Anatomy. Of course, who didn't like Scrubs? And even the new Scrubs is a real comfortable watch. But The Pitt is something else. And I should mention, love St. Elsewhere, but not anything like this. I do not want to give away any huge spoilers, but I'm just going to highlight a few of the great storylines I loved from Season 2, including starting off the Margarita burn of someone with phytophotodermatitis. We mentioned that years ago on the podcast, and I actually had a toddler patient on vacation in Florida, who was somehow helping his parents mix some lime juice. I'm not sure if they used it for their own margaritas, but he spilled it all over himself. No one even thought about it. He went out in the sun, and he got this wicked, bizarre hyperpigmentation on his chest, on his face. That was a fun diagnosis, and it does go away. They also had an intense emergency C-section on the Pitt this season. Gave me PTSD from my short OB rotation back in the day, why I'd never become an OB. And they also highlighted the stress of one of the young residents of getting deposed in a malpractice suit that harkened back to Season 1, the great arc about the non-vaxxers, and the child got measles and they were refusing all therapy, and they were Googling it in the room while the child was coding. Really well done about getting deposed. I also enjoy guessing the diagnosis with each presentation, but I got one spectacularly wrong this season, and it was a pediatric one, and I told all my friends about it, and then 2 weeks later, it blew up in my face. It was a child with easy bruising, rule out child abuse. Someone mentioned for a quick second that the child didn't flinch much when they got an IV. And of course, I went right with that and thought the child had a zebra, congenital indifference to pain, which I saw once in the 1980s, when the child actually had idiopathic thrombocytopenic purpura, or ITP, which is not that uncommon. In my small defense, when I've seen ITP, they've always had a lot of petechiae, which are tiny little red dots, and I don't remember them saying that in the show. But man, I look stupid, stupider than usual, when it turned out I was way off base on that one. The show also highlighted the life-threatening results of leaving a child in a hot car, which I think was really well done. It also showed the entire sequence of someone going through a rape kit, sexual assault kit with the nurse and the patient. I'd never seen that before. I think back in the 80s when I trained, it was not done that way and not as thoroughly, and certainly not as compassionately as this was. Really, I think anybody training should watch that if they're going to be doing those types of kits. But the thing that will stay with me from this season was the arc of Dr. Robbie, the star, the main attending, and his mental health issues, his burnout, his lashing out at others. The whole season starts him out in a motorcycle without a helmet, which is completely nuts, But then I did a deep dive, and I must say both Pennsylvania and Delaware do not require helmets for experienced riders, which is crazy. There are 19 states that have universal helmet laws for motorcycles, including two you'd think, California, New York, but also Alabama, Mississippi, North Carolina. But then other states let you go without a helmet, like Illinois, Iowa, New Hampshire. So, yes, that's just crazy. Wear a helmet. Lastly, the most talked about part of the season in print and in social media was the medical student who was really brilliant, but was really not interested in going into emergency medicine. And after a crazy day, she leaves at the end of her shift, and she's not willing to stay any later to help out. And she basically made the point that the older generation of medical caregivers like Dr. Robbie could learn a lot from the newer, younger generation of trainees about maintaining a good work-life balance. And I do think Matt and I are in the generation that we talk about, well, we were on call every second and third night, and we didn't have any hours that were limited. And if you go home, you miss a lot. But it does make sense that you don't have to kill yourself to be a good health caregiver, and much better to have a good work-life balance. So that's it. I hope to see you all in Disney World in a couple weeks for Hot Topics, July 16th at the Grand Floridian. I certainly will make sure to take my annual Guardian of the Galaxy ride. And this year I'm going off site to Universal Epic. Very excited. Matt can't go this year, and as we all know, he hates all rides. I should mention our disclaimer. We are sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines. And lastly, as a Philadelphia fan, I have to mention that all of us have no idea why the Boston Celtics gifted us Jaylen Brown and let us get rid of the worst contract in the league. But we sincerely thank you, Boston. So good night, Matt. Good night, Moon.
This is Audio Digest. Hot Topics in Pediatrics, Naloxone, Antibiotic Risks, Strabismus, and more. Presented by Robert Walter, MD, Associate Professor of Pediatrics, Sidney Kimmel Medical College at Thomas Jefferson University, Philadelphia, Pennsylvania. Dr. Walter spoke at Hot Topics in Pediatrics 2025, presented by Nemours Children's Health, Jacksonville, Florida.
Want to welcome you all to Hot Topics 2025, our 10th annual, the biggest turnout we've ever had. It's a big room. Welcome. I'm Rob Walter, co-host Podcast Pediatricians, and I do it with a cross-town friend who's a pediatrician, and we're kind of idiots, but we have fun. It's a good way not to burn out, to find something like that. So my top 3 articles of the year, which are, for me, things that might change what I do in practice or relate to office pediatrics or potential game changer or kind of cool. I first want to go back to one of the ones we did last year, which was on the flu, about outpatient therapy with generic Tamiflu for kids under 5. And this is a study that was done that basically said that pediatric caregivers do not follow the AAP guidelines very well for young children, especially the highest risk kids under 5 who are at risk for secondary problems and sinusitis and pneumonia and also community spread, and that the adverse effects are very much overblown, which Neil Velosa, our ID person, would disagree with. He can talk about that. And especially under 5, 34% 2 to 5, 37% under 2. And the editorial was, we pediatric caregivers should use all the tools in our toolbox. If we have a bulging ear, we should give antibiotics. We'll talk about that. But if we have someone who's higher risk under 5, we should use antivirals. And then we get to this year. This year, we had the most pediatric deaths in the United States since the 2009 swine flu epidemic. And a lot overall, flu in adults are driven by getting it in kids. There was a study out a couple months ago about inpatients where they surveyed children's hospitals and they gave them scenarios of when the AAP would recommend that they use generic Tamiflu. And in hospitalized inpatients, less than half would use Tamiflu, or generic Tamiflu. The lowest in hospitalists, 41%, and a little bit more in ER docs. And then what about Peds ERs? So I didn't see a paper, but I asked a colleague, a neighbor who's a CHOP ER doc, what they do there for young kids with fevers and cough. And under 1, they test everybody, 1 to 2 some, over 2, they don't recommend any testing. These are guidelines, doesn't mean they all do that. And if they do get a positive flu test, they treat everybody under 1, sometimes from 1 to 2. And they recommend in their guidelines not to treat 2, 3, 4-year-olds with a positive flu in the first 48 hours. So these are kids who would qualify for it. So I think it could be a future hot controversy. And I think everyone agrees we need more randomized, controlled clinical trials about using antivirals in kids in pediatrics. Some final flu thoughts. How many of you got calls this year? I got a home flu test in my kid. Will you call me in some antivirals? Anybody get that call? So first year we got a lot of them, and our answer was no, that we didn't feel that comfortable without seeing them. But this is only going to get bigger, and they'll find somebody, some telemedicine person out there will prescribe it. So I think that's things to come. And then, of course, it all gets back to better vaccination rates. Is everybody aware that this fall, the home nasal flu vaccine was approved from age 2 to 49? That you call them, you get prescribed online, and they send it to you, and the parents squirt it up your nose. It's only for private insurance, not for VFC. In my practice, I can't get VFC nasal flu for my needle-phobic kids at all. So that's another problem. It's given by the parent. I do think the writing's kind of on the wall that eventually 10 years from now, we won't be giving many flu vaccines. And maybe it's not a bad thing, but it's a big part of my practice right now. So a paper that I think you should know about that didn't make my top 3 is on seizures and first-generation antihistamines in young children in JAMA in September. It was a retrospective study of kids born 2002 to 2005 who went to the ER for seizures before 2020. And they looked at if they got diphenhydramine, Benadryl, often for allergic reactions or hives or colds. And in the study, the young kids, 6 to 22-month-old, the risk of non-febrile seizures was 22% higher if they're treated with first-generation antihistamines like diphenhydramine. So 1, add seizures to the list of other reasons not to use this, like hyperactivity, sedation, delirium, psychomotor slowing, dementia with long-term use, car crashes in teens and adults. And bottom line is, why would we ever use these medications when you can use a second generation? And to that end, shout out to Michelle Squadrito, Nomura's fellow graduate who practices in my community and allergist. I kind of lean on cetirizine if I'm going to use a second generation. Onset faster, lasts longer, less side effects. And she gave me just some guidelines, which is not going to be in the inserts with it, but that's what most allergists do. So basically, it's 1 ml per age. So a 2-year-old gets 2 ml. A 4 gets 4 ml, a 6-year-old gets 6 ml. And then after 8, you can give the adult dose. And remember, for allergies, and Delaware is allergy central, we should always give it at night. So it's working in the morning. And if it's going to be a little sedation, it's 3 in the morning. So that's not a bad thing. And not give it in the morning. And 2 months ago, there was an FDA warning that chronic regular use, and I take it every day, there's a warning that if you do that and then you stop abruptly, a small amount of people get uncontrolled itching, and not just a little itching. And that basically, if you come up with that, just put them back on it and then just wean off slowly. But you should be aware of that. And then, I don't know, I just found this out this year about the allergist guidelines about urticaria, how high you can go with cetirizine, up to 4 times the standard dose. So a 5-year-old with severe hives that are persistent, you can give 10 milligrams twice a day. And a 16-year-old with persistent hives, you can give 20 milligrams twice a day, short term for hives. So I've started really crossing out the Benadryl and putting in cetirizine for all these action plans we do. But one problem is a lot of the nurses in the schools do not carry cetirizine, and that's just the facts of where they are. So sometimes you have to do both on the action plans. All right, my top papers. Number 1, naloxone dispensing to youth. So you got a routine 17-year-old pre-college well visit with Tommy, oldest of 4. You look at his craft screen. He occasionally uses marijuana and alcohol with friends. This is like a typical day, right? And kids will see. He's a good student. He's on ADHD meds, negative G87, PHQ-9. You advise him the dangers of illicit drug use and alcohol. But in addition, based on a recent paper in pediatrics, you A, discuss having naloxone in his dorm room. B, recommend naloxone for his dorm room with shared decision-making with the parents. C, you recommend naloxone for his dorm room and discuss about having it in the parent's home. They've got 3 other kids coming up. Or D, you do not mention naloxone at all. And so you're not voting on this, but just think what you'd answer. And I got to say, most of my career, it's D. I wasn't really bringing this up at all. So background, no surprise to all of us pediatric caregivers about the wave of synthetic opioid overdoses, fentanyl combined with methamphetamines or marijuana, or in pills that look just like opioids or benzoids or stimulants. And the youth death rates are rising 3-fold higher than adults. Pediatric fentanyl deaths up 30-fold since 2013, mostly 15 to 19. 40% of these deaths are in the home and 87% unintentional. And often, 2/3 of the time, there is somebody there, but they really didn't have much help to give except trying to do CPR. And even in the ER, one study showed that if you went to the ER with an opioid overdose, you rarely got prescribed naloxone when you went home. Intranasal naloxone can reverse overdose, safe in infants, children, teens, and now it's over the counter. So the paper on naloxone dispensing to youth ages 10 to 19 from 2017 to 2022 by Taranella out of Pediatrics in October from the CDC. It's the first national estimate of naloxone dispensing in youth. And the dispensing went way up over those 5 years, up 669%. And each year, the percentages went higher. Pediatrician prescribing went up 991%, but was only 5.6% of the overall prescriptions for naloxone. Well behind nurse practitioners, physician assistants, surgical specialists, family medicine. Their conclusion was that youth naloxone dispensing remains low, but is increasing. And I quote from the paper, pediatricians are in a unique position to offer naloxone along with harm reduction education, augmenting community distribution, and expanding over-the-counter access for this life-saving drug. There's a really nice commentary by McKnight from Nationwide Children's that talked about historically, we only gave this if there was an overdose or substance use. But given the recent epidemic, that universal naloxone prescribing should be considered. Cost can be a barrier. It can be very cheap on naloxoneforall.org. Over the counter around me, it's about $50. If you prescribe it, it can be less. And he mentioned in his editorial this simple sentence to start the discussion: may I speak to you about ways to keep your family safe from overdose? So my takeaways, again, I'd never done this before. I am now talking about it, not in every visit, but in certain visits, especially pre-college visits. I am prescribing it. I prescribed it twice on Monday, and people are very open to say, yes, that'd be good to have. I'm not yet universally advising it, but we'll see. It's very easy to use. It's almost like you'll hear about the Neffy intranasal epinephrine, and same dose for any age. And while I'm on this general subject of listed drugs, I just want to make the plea. I couldn't put it into paper, but is everybody asking about Zins, about nicotine patches? I mean, it's horrible out there. And it's like the Wild West. It's these patches with high dose nicotine that is very easy to get. And it's in all kinds of flavors. Really, it's an on-ramp, another on-ramp for nicotine addiction. And also there's a paper this month in Pediatrics about the incredible rise of nicotine toxicity in young children. And many of them, it's this. It smells good. The kids get it. They take a bite out of it. So you ask, you're going to find a lot about people using nicotine pouches. Anybody out there prescribing naloxone or routinely talking about it? Okay. Oh, good. Because I'm not saying you're going to, but it was just like that too. And it really made me think about it. So speaking of NPs and PAs who were doing this better than pediatricians, a survey 2 months ago out of Vizient said that over 40% of U.S. healthcare workforce are nurse practitioners and physician assistants. It's driven by primary care. In the next 5 years, it'll probably be over 50%. So who out there is a nurse practitioner, physician assistant? First of all, thank you for coming. We're all on the same team, and we all have to keep learning. And I just added this because in hiring some physician assistants and nurse practitioners, I found that a lot of them came from practices that didn't give them things like up to date. I have no financial connection, but if you talk to surgeons, subspecialists, they all use this. And I use this all the time, and you get CME credit. So we need to make sure that that's available to all the practitioners. So second paper, early antibiotic risk. You're seeing a 23-month-old with acute ear infections. He was treated with Amox for otitis at 12 months, got azithromycin at 20 months, probably during the fall when everybody had mycoplasma. And then 3 weeks ago at urgent care, he got Augmentin for otitis. Now he has another bulging ear. Mom asked if there are risks of frequent antibiotic courses besides antibiotic resistance for her young child. And you remember a recent article in the Journal of Infectious Disease associated with early antibiotic exposure that showed an increased risk for all the following except asthma, intellectual disability, food allergies, or autism. So just think about it. What would you guess? It's a hard one, I thought. Background early antibiotic risks to children. There's just been many studies. I don't know if you've been kind of paying attention about all these issues about early antibiotics and increased risk of chronic issues in allergy, asthma, allergic rhinitis, eczema, food allergies, autoimmune diseases, celiac, type 1 diabetes, psoriasis, neurodevelopmental psych, ADHD, autism, anxiety, intellectual disability. The mechanism conjectured is that these early antibiotics disrupt the human microbiome, the dysbiosis in these young children, and it affects the development of their immune system, but also their nervous system and their frontal cortex and the amygdala gene expression. But these studies are hard to do. It's hard to know if there's a straight line between early antibiotics and all these things, many of them diagnosed years later. So they really tried to control for many of these things, but there's always concern in these prior studies about unmeasured confounding variables. So the paper, Early Childhood Antibiotics and Chronic Pediatric Conditions by Bayer, Journal of Infectious Disease in April out of Rutgers, the hypothesis again was about the microbiome being disrupted. It was a retrospective cohort study from UK using their primary care EMR database. And it is an amazing database. They have National Health Service. Everyone in the country uses the same one. So it can't really be replicated anyplace else. And they looked at kids under 2 with antibiotic exposures and outcomes until their 12th birthday. And to prove their hypothesis, they wanted to see a positive dose-dependent association. So the more times you got antibiotics, the higher risk of getting the chronic condition. And they thought they should see stronger effects with macrolides and cephalosporins versus penicillins because they have more profound effect on your microbiome, especially macrolides. So many statistics that I didn't understand, but what they said they did better is they measured effects of repeated antibiotic exposures and then class-specific effects of the penicillins, cephalosporins, and macrolides. They tracked cohorts with the same mother, so they had sibling match controls. So there's nothing better to say, well, these 2 kids in the same house and the same parent, genetic-wise and environmental, it should be easier to rule out confounding variables. They looked at other things, maternal comorbidities, concomitant medications and illnesses, perinatal risk factors, maternal infections in pregnancy, socioeconomic factors, over 1 million kids eligible. The 686,000 of them got antibiotics 0 to 2. That seemed to track well, I think, what we did. Maybe ours in the US are a little bit higher even. So their results, doing age-adjusted hazard ratio. So what that means is that if it's less than 1, then it is a lower risk by getting the antibiotics. If it's 1, it's about no change. And if it's greater than 1, there's an increased risk. So 1.3 means 30% higher risk of having the condition. And finally, most striking was under allergic conditions, very strong risks for food allergies, 33% higher if they got early antibiotics. And that went to over 53% higher if there were 4 courses of antibiotics. For asthma, 23% higher, but over 50% if they got greater than 4 courses. For eczema, 7% higher, no dose-related changes. Then for allergic rhinitis, 6% higher, but definite, statistically significant increased risk with more courses. They did see more association with macrolides, but didn't see that as much in the sibling match controls. How about the autoimmune diseases? Nothing. So all these diseases, negative, no change in risk, a little bit statistical association, none of them held up. And then how about the neurodevelopmental psych? So for ADHD, 8% higher risk, but it wasn't seen in sibling match controls. And for autism, no increased risk. Anxiety, no increased risk. And then their surprise was intellectual disability, 9% increased risk, but a really strong association with sibling match cohorts, and especially with cephalosporins, 43% increased risk, and macrolides, 35% increased risk, and almost 300% increased risk if someone got more than 4 courses. So this was unexpected how strong it was, but as I'll mention, there wasn't that many numbers of this, so they still think it's unvalidated, but chilling and something we should look into more. So their conclusions in this large population, positive dose-dependent associations between early antibiotics and asthma, food allergies, intellectual disability and allergic rhinitis. Of course, association doesn't prove causation. No strong evidence, any connection to autoimmune or ADHD or autism. And then this stronger expected relationship with intellectual disability, but they feel at this point they have to say that it's unvalidated. And their bottom line was there's a steady and mounting evidence of long-term harms from early life antibiotic exposure. So my takeaway was, again, this is kind of chilling, and maybe it's not just under 2, maybe the 2.5-year-olds and 3 that we have to think about. And we just need more studies on the microbiome and how this is all connected, if we can do something to prevent it. Some studies on giving probiotics, which a lot of us do, like maybe so don't get diarrhea, they've not been very strong for this, but we need to look at it more. We obviously need more judicious prescribing and antibiotic stewardship, maybe stricter diagnostic criteria, diagnosing otitis media. That's known that all pediatricians will probably give antibiotics to kids who don't need it if they're viral and such. Maybe quicker referral for tubes. You see the AP guidelines, 3 or more in 6 months or so. On the other hand, the window of susceptibility that by the time they get the tubes, that maybe they weren't going to get another one. So there's that balance. I had a kid Monday, 7-month-old, had his second bulging ears. Both the parents had tubes. I'm like, you're going to see the ENT now. We're not going to wait for you to hit number 3. So that's the part about what we do in the office. And then delabeling for amoxicillin allergies, so we don't have to use cephalosporins and macrolides. How many out there are delabeling in their office? Great. So I talked about this last year. I started doing it. You can get paid for it. And I encourage people to look into that. It's really easy to do. So in this list, the one that was not increased risk was autism. There's talk out there that someone's going to announce in November all the causes of autism. So I await that. But based on this paper, one of them is not increased antibiotic exposure. Last paper, strabismus in animated films. An 8-year-old Jim on his well visit. We talk about his strabismus and patching and glasses. It's getting better, but he's self-conscious. And he states that in animated movies, that people with autism are scary, clumsy, or stupid. And based on a recent study, you tell little Jimmy, no, you're not aware of any movies that would suggest that, or B, acknowledge that he's correct, but it's not accurate. Even beloved animated movies can be wrong. So background on strabismus, we all know what that is. The major causes can be either issues with the muscles or refractive errors. But a lot of studies about kids with strabismus growing up have a lot of social isolation, stigma starting at age 6, school phobia. Other kids won't sit next to them. They don't get invited to birthday parties. It's really sad. We all know that kids spend more time with media than in school. And we all know prior studies show that children's animated films can negatively portray people with obesity, disabilities, darker skin color, elderly, and then in an article this month in July in Peds, facial abnormalities. So the paper on depictions of strabismus in animated films and pediatrics in December from Colorado reviewed films from 89 to 2022 from the major studios. 125 met that criteria. They found 46 characters with strabismus. 13 of the 46 were primary or secondary. And in these 46 characters with strabismus, 30% of them were clearly unintelligent versus 2% that were intelligent. 58% were mute or did not speak. More villains than heroes, much more followers than leaders. 24% were frightening, 35% were clumsy, and 35% had other deformities. So in the appendix, you really have to search for it. They finally told you what movies they looked at. So I just picked a couple out. Lion King, love that movie. First movie my son ever saw. Ed the hyena. Do you remember Ed the hyena? He's the only named Lion King character who cannot speak. And he's just shown chewing his own limbs, communicates with manic laughing. As Scar said, you could tell by his vacant expression, the lights are not all on upstairs. And then Hey Hey the Rooster. Who likes Hey Hey? Who likes Moana? So Hey Hey the Rooster, constantly exotrophic roving eyes. And the intention by the animator was to make Hey Hey the stupidest character in the history of Disney animation. And then Scuttle from Little Mermaid, clueless but not too bad. And then Iago, who is evil, but then he redeems himself at the end. So I never realized that. Everything is intentional with animation. They do it from scratch, and we should advocate for them to do better. So again, we need to tell little Jimmy that, yeah, he's right, but hopefully it will get better. So thank you.
Audio Digest, copyright 2026.
Podcast Pediatricians Productions. All rights reserved.